My name's Colin Martin from NHS Greater Glasgow Medical Physics. I want to talk about the systems that we have in place for testing X-ray equipment and measuring doses in Scotland. Next slide. In the UK, we have fairly rigorous legislation that requires justification of any X-ray exposure. We have requirements for testing of performance of X-ray equipment, carrying out patient dose surveys and comparing results with diagnostic reference levels. And we also have professional guidance prepared by professional bodies in collaboration with the regulatory authorities, which gives interpretation of compliance with the legislation. And through this, we've been able to keep the overall dose to the population in the UK down to 0.4 millisieverts per year from medical exposures. Next slide. In Scotland and the rest of the UK, we have regional medical physics departments which provide the scientific support for all the X-ray equipment within the area. And so these departments have staff who go out and test equipment and also undertake patient dose surveys. And we also link in with the radiographers performing the X-rays, providing them with quality assurance tests for them to perform and linking in them with them in the optimization of protocols. Next slide. In Scotland, we have 5 regional departments. We have a total population of 5.5 million. So an average regional department serves a population of between 1 and 1.5 million and might have a staff of perhaps 6, partly physicists and partly technologists. Next slide. We perform the routine tests on the CTDI in air, in phantoms, and image quality tests. Next slide. And we also set diagnostic reference levels for a range of different examinations. Now, these are based on national diagnostic reference levels. These were first used in the UK for computed tomography in 1995, and since that time have been revised about every 5 years. But we also have local DRLs, which we adopt or base mainly on the national DRLs, but also incorporate local differences. And we undertake regularly, every 1 to 3 years, surveys of patient doses and compare the mean results for each hospital or each X-ray room with the DRL values. Next slide. This summarizes the DRLs that we have in place for computed tomography at this time. You'll see we have quite a range, and some of them are linked to particular clinical reasons. Next slide. Now, the patient dose survey and optimization process follows something of the form I've shown in this flow chart. So surveys are undertaken. The mean patient dose will be calculated for each CT scanner. The result will be compared with diagnostic reference level. If it's below that level, then no further action will be taken. But if it's above the level, then we'll go through the other information that we've collected on the scans performed, and we'll look into the optimization of the protocol and then go round and do another survey around the audit loop. And we repeat this process every 1 to 3 years, depending on the particular scanner. Next slide. So data collection consists of putting together results from 20 to 30 patients. These usually collected at the present time in paper form, but we also have information on all the settings, the dose results, and we only take patients within a standard weight range, which might be 60 to 80 kilograms or 50 to 90 kilograms. Next slide. This shows results for the dose length product ordered sequentially for scanners throughout Scotland for the chest, abdomen, pelvis examination. And you'll see there's just a few at the top which are above the red line, signifying the diagnostic reference level. And so we'll put in extra effort to try and reduce the doses for those particular examinations or those particular scanners. Next slide. This shows results, the same results, but with box plots showing the first and third quartile and lines showing the range of doses for the different patients. So you see for some scanners there's a much wider range, and so we were interested in why this was. We realized that some of the scanners were giving very much higher doses for large patients. So we took, next slide, so we took results for all the scanners. We interrogated the packs to obtain information on the images, took measurements of the sections at particular locations along the body. We also prepared a program that was able to identify the regions of blood within the heart and make measurements of the noise level in sequential slices through the heart. Next slide. And this picture shows results that we obtained plotting the CTDI against the patient cross-section and plotting the noise levels against patient cross-section. So you see for the Toshiba scanner, as the size of the patient increases, the CTDI increases quite rapidly, whereas the noise in the image remains constant. In the Siemens scanner, there's a slight increase in both of these. So the Siemens scanner doesn't keep the noise at the same level, but it doesn't allow the patient dose to creep up. And the Philips scanner performs in a similar way to the Siemens. Next slide. Now, in order to investigate this further, we have an elliptical conical phantom developed by Impact, which we use to test the automatic exposure control of all the scanners. Next slide. This shows results for the Toshiba scanner with the phantom, and you can see as the dimension of the phantom increases, the MA slowly or gradually increases. With the noise level remains relatively constant and increases towards the end when the maximum tube current allowed is reached. Because of this rapid increase in the tube current, this means that the heavier patients get a much larger radiation dose. And so in order to avoid this, we've adjusted the protocols for the patients so that the higher noise level is allowed for larger patients in order to keep the doses down. The GE scanner has a similar pattern to the Toshiba scanner, and so we've followed a similar regime for that scanner. Next slide. Whereas the Siemens scanner and the Philips scanner, both the tube current and the noise level gradually increase, as we saw in the patient images. So we're using this conical phantom to identify the noise and MA relationships of the automatic exposure control, so we won't have to do as detailed assessments of patients in the future. Next slide. So in summary, the United Kingdom uses regional medical physics departments which provide medical physics support to all the CT scanners and all other X-ray equipment within the region. Comparisons are made between results from patient dose surveys and diagnostic reference levels, and then where the results are found to be higher than diagnostic reference levels, then we work with the radiographers to optimize the protocols for the patients. Next slide. I'd like to thank a number of my colleagues in different centres for contributing to this work and helping our optimization program. Thank you very much.